heart failure education. My gloriously persistent scholars, still here, still learning, still ignoring sleep hygiene. Perfect. Let's make heart failure unforgettable. So when the lungs gurgle and the ankles shimmer, you'll know exactly which spell to cast. What it is? The syndrome, not the sentence. Structural or functional heart dysfunction leads to inadequate cardiac output and/or elevated filling pressures, causing dyspnea, fatigue, and fluid retention. It loves company: hypertension, diabetes mellitus, and chronic kidney disease. Compared to pericarditis' squeaky hoodie and aortic stenosis's rusty gate, congestive heart failure is the whole haunted house flooding from the basement. Etiology. Who flooded the mansion? Cardiac culprits include CAD and MI, the most common, where myocardium is lost, like texts you shouldn't have sent. Hypertension involves years of pressure leading to LVH and diastolic doom. Valvular causes such as MR, AS, AR, and rheumatic disease cause volume or pressure overload. Cardiomyopathies like HCM, DCM, RCM, and ARVC also contribute. Non-cardiac instigators include diabetes, CKD, obesity, and aging physiology. Infections like myocarditis and endocarditis, alcohol use, and a sedentary lifestyle are additional factors. Mnemonic to remember these causes: hard valves. Pathophysiology. The vicious waltz. Initial insult leads to decreased cardiac output and increased left ventricular filling pressures. Compensation, which offers short-term help but is a long-term curse, involves the sympathetic nervous system and renin-angiotensin-aldosterone system revving up, causing vasoconstriction and sodium and water retention. Remodeling occurs with myocyte hypertrophy, dilation, and fibrosis. The heart's geometry becomes tragic. Frank-Starling mechanism works until it doesn't. Decompensation leads to pulmonary edema, congestion, fatigue, and hospital bracelets. The villain roast? Race, because nothing says I love you like keeping all the salt. Mnemonic. Sir drowns. Classification. Name the beast. By EF. HFrEF means LVEF, less than 40%, which is our best evidence for drugs. HFMREF ranges from 41 to 49%, considered the middle children. HFPEF is 50% or greater, plus diastolic dysfunction, giving stiff vibes. By symptoms according to NYHA classification. Class 1 means no limits. Class 2 means ordinary activity leads to symptoms. Class 3 means less than ordinary activity causes symptoms. And Class 4 means symptoms occur at rest. Clinical features: how the house leaks. Cardinal symptoms include dyspnea, starting with exertional, progressing to orthopnea, and then paroxysmal nocturnal dyspnea. Patients also experience fatigue and exercise, intolerance. Fluid retention is common, presenting as edema, ascites, and weight gain. Other symptoms include nocturnal cough, early satiety, nocturia, low mood, and brain fog. On examination, signs include tachycardia, displaced apex beat, S3 gallop, and murmurs. There may be raised jugular venous pressure, basal crackles, pitting edema, hepatomegaly, and pleural effusions. The patterns of failure are as follows. Left failure causes the lungs to drown. Right failure causes the legs and abdomen to drown. And biventricular failure causes both to drown. Remember the mnemonic. Dope faces. Investigations prove the flood. First line NICE guidelines recommend NT-proBNP for all suspected heart failure cases. Levels greater than 2,000 per/ml indicate referral to a specialist and echocardiogram within 2 weeks. Levels between 400 and 2,000 require specialist referral and echocardiogram within 6 weeks. Levels less than 400 make heart failure unlikely, but be mindful of red flags. Echocardiogram, specifically transthoracic echocardiography or TTE, assesses ejection fraction, chambers, valves, diastology, and pulmonary artery pressure. ECG and chest X-ray are used to evaluate rhythm. Atrial fibrillation is commonly associated with congestive heart failure, myocardial infarction scars, cardiomegaly, and congestion. Blood tests include full blood count, urea and electrolytes, liver function tests, thyroid function tests, glucose or HbA1c, lipids, iron studies, and troponin when the patient is unstable. A useful mnemonic to remember these investigations is B-Echo-MAP. Diagnosis: 3 locks to open, typical symptoms and signs, and elevated natriuretic peptide unless low, and objective dysfunction on echo. Type your foe: HFrRF, HFmrEF, or HFpEF. Management: 3. Drain the house, fix the foundations. 0. Treat the cause and teach the craft. Ischemia treated by PCI or CABG, valves through repair or replacement. Atrial fibrillation managed by rate or rhythm control and anticoagulation according to K2DS 2 VASC. Hypertension and diabetes mellitus. Lifestyle modifications include cardiac rehabilitation, salt sense, smart fluids, cessation of alcohol and smoking, vaccines, and daily weights. 1. HFrEF guideline pillars, also known as the 4 horsemen who save lives. Mnemonic: BAMS, Sutherland Slam heart failure with BAMS. Beta blocker, evidence-based. ARNI, which is sacubitril, valsartan, or ACE inhibitor, or ARB, if ARNI not feasible. MRA, such as spironolactone or eplerenone, and SGLT2 inhibitors like dapagliflozin or empagliflozin, effective regardless of diabetes status. Add loop diuretics for congestion to provide symptom relief. Consider ivabradine and hydralazine ISDN in selected groups. 2. For HFpEF and HFmrEF, control blood pressure, use diuretics for symptoms, treat atrial fibrillation and ischemia. And note that SGLT2 inhibitors are now beneficial. Mineralocorticoid receptor antagonists and ARNIs may help in certain phenotypes. 3. Devices and procedures include the ICD for primary and secondary prevention of sudden cardiac death in eligible HFIEF patients, CRT for those with left bundle branch block, wide QRS with dysynchrony plus HFrEF, and advanced options like left ventricular assist devices and transplant for refractory cases. Pickup line: are you an SGLT2 inhibitor? Because when you showed up, my admissions went down. Complications, side quests of doom, arrhythmias, AF-VT, leading to stroke and sudden cardiac death. Pulmonary edema results in recurrent admissions. Remodeling causes dilated geometry and mitral regurgitation. Cardiorenal and hepatic congestion leads to nutmeg liver. Thromboembolism, cachexia, anemia, and iron deficiency are also complications. Mnemonic, fragile. Prognosis, the clock, rewritten. 5-year survival is about 50%. Worse with advanced class, low EF, frequent decompensations, high NT-proBNP, and major comorbidities. But early BAMs, diuretic finesse, devices, rehab, and treating the cause. The curve bends. Remember, aortic dissection demanded the scalpel now. CHF demands discipline forever. My steadfast storm chasers, heart failure is not a plot twist, it's a long season. Find it with BNP, define it with echo, decongest with loops, and save lives with BAMs. Teach your patients the rituals, weigh, walk, and watch the salt. Now, unburden your mortal curiosities below, because I shall roast 3 comments in the comment section.